Hello and welcome to this week's episode of the Metabolic Classroom through insuliniq.com. I appreciate, as always, the fact that you're joining me. I'm delighted to be able to be your professor again for another classroom. Today, we are continuing our theme focusing on fat tissue. Fat tissue, what I've hoped to impress upon you by now is that it is far more than simply an inert tissue that only acts to store energy for later use. While that is certainly an important part of it, today we're really exploring an oft overlooked aspect of adipose tissue, namely its role as an endocrine organ. Now, you've heard the term endocrine organ before, I'm sure. If you haven't heard that term, you certainly are familiar with the classic endocrine organs. These are the glands within the body, the tissues that produce hormones and release these molecules into the bloodstream to have effects throughout the body. And some of the more famous endocrine glands are things like gonads, ovaries, and testes, or the thyroid gland, or adrenal glands. All of these are tissues you've heard of before. And they're famous because they are releasing their energy, or they're releasing molecules into the bloodstream. Now, some of these are inert from various tissues, or only have a modest effect. And then some, the ones that are coming from fat tissue, have, or each, let me say that all another way. Each endocrine organ has hormones that will have very specific effects relevant to that tissue's function. And the fat tissue is related to metabolism. And so it's no surprise that its hormones have a metabolic influence. And that's really what I'm going to share with you as we go through some of the specifics of the hormones. But a couple that I'm going to mention, appear to not influence metabolism and have very unrelated effects. All right, so some of the hormones that we're going to cover, as I mentioned, they're going to include ones that are overtly metabolic in theme, like leptin. But then there are going to be others that are less metabolic and more pertaining to, say, sex, because fat tissue has a surprisingly important influence in sex hormone production at certain times of life, and we will cover that, but hint, it has to do with menopause. In fact, with menopause in mind, let's just start there as we start talking about the endocrinology of the adipose tissue. Men and women are not the same, and we store fat in very different places. Now, in the previous episode, we discussed why men and women store fat differently, and it is entirely a function of sex hormones, where the sex hormones induce the expression of lipoprotein lipase in different fat depots throughout the body. For example, just as a brief recap, the higher estrogens in the woman, or the girl who's going through puberty, result in higher expression of lipoprotein lipase at the prototypical female areas like breasts, hips, and buttocks. Whereas the androgens, like testosterone, which are much higher in the boy, the male going through puberty, that begins expressing more lipoprotein lipase in the central region of the body, leading to greater abdominal and even visceral fat storage. Now, we store fat in different places between the two sexes, and those different depots have differing effects on hormone production. So, for example, in women, because women have relatively much higher levels of subcutaneous fat, it's no surprise that she will have relatively higher levels of the hormone products that come from subcutaneous fat. And I'm going to go into the details of these hormones in more complexity in just a bit. But for example, she will have higher levels of hormones like adiponectin and leptin, which are much more abundantly produced from subcutaneous fat cells than her male counterparts. Whereas the male, while having relatively lower levels of those hormones from fat cells, will have relatively higher levels of hormones or signals that are coming from central or even visceral adipocytes, like TNF alpha. Now, TNF alpha we are justified in calling it a hormone, but it also meets another characteristic, and it is also called a cytokine. A cytokine, that is the term to refer to these proteins that influence inflammation and immune functions. So where we have more visceral fat, we're going to be producing relatively less of hormones like leptin and adiponectin, and we're going to go into a much longer list in just a moment. And then relatively more of the pro-inflammatory signals. And there's even another one that I'm going to mention in a moment. So where we store fat, which is heavily influenced by our sex, will also then in turn heavily influence the production of hormones. Now let's just talk a little bit more about menopause. Menopause is a unique change in the woman's certainly her fertility, but as a result of that change, her hormone production. So the main cells of the ovaries that are producing sex hormones are the granulosa cells and the theca cells. And they normally will they will proliferate, or you'll have much more of those cells surrounding follicles, which is a little egg, kind of a wrapped up egg within the ovary. And during menopause, as she transitions into menopause, it's essentially her ovaries running out of follicles. As the ovary runs out of follicles, it's no surprise that the relative amount of granulosa cells and theca cells, which again are the two cells that are producing sex hormones, is diminished. So not only does this result in the ovary actually shrinking, it does get smaller, but the relative composition of the ovary, so the cells that make up the ovary, starts to shift somewhat. And as the granulosa and the theca cells go down in number, other cell types like fibroblasts go up. Now, a fibroblast is really the cell type of connective tissue and even scar tissue. Now, that's not to say that the ovaries are becoming scarred, but they're becoming a little more fibrotic, so a little less functional. And in that stage, the main source, so the ovaries normally, we've talked about this abundantly before, but it's very relevant to this lecture today. The ovaries are very involved in this process called aromatization. Aromatization it's admittedly an unfamiliar word, but it refers to this process of converting androgens to estrogens. And I am deliberately using the plural. Creating estradiol from testosterone, creating estrone from androstenedione. So taking androgens, the prototypical male sex hormones, and converting them into estrogens, the prototypical female sex hormones. After all estrogens were once androgens. You cannot get to estrogens without first passing through the androgens. And to do that, to actually make that conversion, you need this enzyme called aromatase, which is why we've turned it into a verb and say that we have this process of aromatization. So ovaries are good at aromatizing androgens, or converting testosterone to estrogens, if you will. Now, as the theca cells and the granulosa cells are reduced in number with menopause, there's less androgen production and thus less aromatization happening in the ovaries. In this stage of her life, most of her androgens actually are now coming from her adrenal glands, which is a topic for another time because it is its own beast. So the adrenal glands become the primary source of androgens in her body. Now, still, they need to be converted to estrogens, and this is where the fat tissue comes in, because in the postmenopausal woman, the fat tissue is the main source of estrogens. Now, it's not making them from scratch. Remember, the fat cells are simply pulling in the androgens, and in this case, the androgens that are coming from the adrenal glands, and converting them into estrogens. So I'm just going to repeat all of that because it's a fascinating change in her body as the ovaries become less active. Not that they're gone and not that they're not contributing at all. They still are, but they're no longer the primary source of sex hormones. Most of her androgens, like testosterone, are now coming from her adrenal glands rather than her ovaries. And then most of the androgens that are getting converted into estrogens are doing so in the fat cells rather than the ovaries where it used to happen. So her fat cells in the female with menopause are very, very important in this process. All right. So again, this just to remind you, the overall topic is us talking about the endocrinology of adipose tissue. And here it is very, very relevant because the adipose becomes the primary source of estrogens in the postmenopausal body. Now, I somewhat touched on this as we transition into the next subtopic here, talking about the expression of fat cells. I got a little ahead of myself earlier, but I'm just going to repeat it here because it's relevant as we get into the specifics of the individual hormones themselves. So generally, and you can take this to the bank, it's pretty reliable. Any of the hormones that are coming from the subcutaneous fat are going to be good hormones, metabolically favorable. These are going to be hormones that improve insulin sensitivity, reduce inflammation, and promote satiety in general. Now, some of those things can go sideways, as we'll talk about more in a moment. In contrast, visceral fat tends to be releasing hormones. And again, I'm including pro-inflammatory proteins in this because they do meet the classification of a hormone. They're generally going to be higher from visceral fat. So visceral fats, typically whatever it's releasing is generally going to be less favorable. Not completely. These are generalized statements, no doubt. Now, one other comment on the cytokines that I am inclined to revisit, which is how do we define a hormone? What is a hormone? How does a cell talk to another cell? Well, there are different ways, but if a hormone is released in the blood, if there's a molecule that one cell releases into the blood, and then this molecule flows through the blood and then has an effect at a cell that is somewhere else in the body, that is an endocrine signal. And therefore, based on the way I view it, and specifically as a professor who teaches graduate level endocrinology, I would call that a hormone. Even though in the case of some of these, one in particular that we're going to discuss, it's also called a cytokine because cytokines are the terms, it was the title given to these molecules that will activate immune processes, but it's still a hormone. All right, now let's get into the specific hormones. Let's highlight some of them. Emphasis on some of them because the fat cells are fantastically complicated. That's not the right word. They are fantastically involved endocrine glands. So they secrete a lot, dozens of hormones. And we don't have time to go into all of them, and many of them are kind of boring. So I wanted to just highlight the 6 or so most compelling and the ones you might be familiar with and or the ones I think you should be familiar with. And remember, part of my hope as your professor for this classroom is that there is actionable information, actionable either to the manifested with you being able to actually make lifestyle changes and or actionable in that it's a relevant or interesting detail that you can then go and teach to someone else. That is always my goal. Can I create teachers? Because you understand the material so well and you see its relevance. All right, the first hormone from fat cells is probably the most famous. To my knowledge, it was in fact the first discovered hormone, namely leptin, from the Greek word leptos, which means thin. Now, the story behind leptin is actually quite interesting, and let me just for kicks elaborate on it, although I wasn't planning on doing this. It's just so interesting. So leptin was discovered in this very large mouse colony housed within a lab. This was a lab on the East Coast at a university, and they found that some of the animals were really, really fat, and they were insatiable with their appetite. They would not only eat all the food you gave them, they would also be nibbling on the pellets, the wood. They would eat their own waste. They were just insatiable, and they would become these fantastically chubby little mice. When they dove into this a little more, they found that there was a particular hormone that was expressed differently in these animals. Indeed, these animals appeared to have little or none of it. And that was what they called leptin. Now, the story ends up getting a little more complicated, including they, of course, patent this. They start producing it. A drug company buys the rights and begins going through clinical trials to test the efficacy of leptin at mitigating human obesity. And it just totally crashes and burns for reasons that we're going to get into now. Why is it that treating an overweight person with leptin doesn't help? It's because they already have a lot of it. And so let's talk about leptin. So leptin's most famous effect is to suppress appetite or to promote satiety by acting centrally in the brain, in the hypothalamus. But it goes beyond that. Most people, even highly educated people, don't know that leptin actually has systemic effects. It increases fatty acid oxidation. It increases mitochondrial biogenesis in the muscle. So it promotes insulin sensitivity. So the leptin has many more effects than just the central effect on satiety that are all very relevant. A totally unappreciated effect of leptin is how completely essential it is to tell the hypothalamus to create the first hormone called gonadotropin releasing hormone, to tell the pituitary gland, which in turn will tell the gonads when it's time to actually be fertile. So it is leptin that explains why, in particular, a young woman or even an older woman who's too thin, who doesn't have enough fat tissue, that they will not be fertile. They will not ovulate and have no menstrual cycle. So again, this is why if someone gets too skinny, especially a young woman who's more sensitive to leptin and needs it more, they will not ovulate. They will not menstruate. They will have no menstruation, no menstrual cycle if there's not enough leptin. So as much as we talk about leptin in the context of metabolism, we could also talk about it completely in the context of fertility, because no leptin means no fertility. And let's just pause for a moment and appreciate how genius this is.
Yes.
Leptin is a signal that comes from the fat tissue. And thus, it kind of becomes a way for the fat tissue to tell the brain that the body has enough fat, enough energy stored that it can undergo the energetically rigorous process of fertility, of getting pregnant. After all, the female body has to carry the metabolic burden of pregnancy and even the metabolic demands that come with lactation, which is considerable. So all of that fat tissue is essentially her body's way of telling the brain that there's enough energy to reproduce. So leptin is completely essential with reproductive health. Leptin is also relevant with bone health and bone recycling, the formation and the remodeling of the bone, another totally overlooked effect of leptin. So a lot of systemic effects that have nothing to do with satiety and hunger. Okay, now one final note, then I'm going to do this with each of the hormones we cover. And this is totally unique. And no other endocrine glands will change the production of its hormone based on the size of the gland. So for example, if you have a thyroid gland that gets bigger, it's still producing abundant thyroid hormone. If the adrenal glands somehow got bigger, it still is producing the adrenal gland hormones, which are a lot. But when it comes to fat tissue, and leptin in particular, as fat tissue goes up, so too does leptin. So as fat cells in particular are growing, undergoing hypertrophy, leptin levels will continue to go up. That's not a great thing. Now, I just got done elaborating all the ways in which leptin has metabolically favorable outcomes. And now I'm telling you that it's not a good thing. It's because too much of a good thing can become a problem. Namely, the body starts to become leptin resistant. Leptin resistance with too much leptin. That sounds familiar because the same thing happens with too much insulin. Too much insulin causes insulin resistance. The same thing happens with leptin. As the fat cells swell ever larger, their production of leptin grows ever higher, and the body becomes resistant to it. All right, now let's leave leptin behind and go to another one. namely adiponectin. You might not have ever heard of adiponectin, but it is a very relevant hormone, and indeed so relevant that there are drugs that are attempting to mimic its effects. One direct effect is that adiponectin enhances insulin sensitivity throughout the body. So if you have an insulin-resistant tissue, adiponectin starts to reverse that. Similarly, and even related to that, it has an anti-inflammatory effect. So if there is a tissue or a cell whose immunity has been turned on, adiponectin helps turn it down. Also, adiponectin has been shown to reduce the risk of cardiovascular disease by directly acting to reverse atherosclerosis. So here we have not only the overt metabolic benefits, but even an overt cardiovascular benefit. Now, unlike leptin, as a fat cell is undergoing hypertrophy, it begins to produce less adiponectin. So more fat usually means less adiponectin, or I should say larger fat cells means less adiponectin. Now, with these two hormones in mind, one of the tools that my lab and other labs have used in order to have a surrogate marker of fat cell size is the adiponectin to leptin ratio. Now, to remember the relevance of the fat cell, you need to go back and listen to earlier metabolic classrooms where even within just the last 2, we've talked about it, but certainly within the last 10 or so, we've mentioned it a few times. But the larger the fat cell gets, the more problematic it becomes. It's not really a matter of how much fat mass a person has, but rather the size of the fat cells. So the larger the fat cell, the more leptin and the less adiponectin. Thus, if the adiponectin to leptin ratio is going down over time, adiponectin to leptin ratio going down, that suggests that the adipocytes are undergoing hypertrophy. If someone were to measure this and they found that their adiponectin to leptin ratio were going up, it would suggest that the fat cells were shrinking, which is, of course, going to be an overall favorable metabolic change. Now, let's get on to the next one, estrogens. And this is, of course, the process of aromatization of the androgens within the adipose tissue. Estrogens do have metabolic effects. They promote insulin sensitivity. They promote fat burning. It generally promotes greater subcutaneous fat, which is a healthier place to store fat. It promotes bone strength by improving the recycling or the turnover of the bone, pulling away old bone and helping lay down new, stronger bone. And of course, it's essential for reproductive health in females, but even relevant in males as well. Now, as I noted earlier, the fat cells in this aromatization becomes absolutely essential in the postmenopausal woman, but it's also relevant even premenopausal. But in the premenopausal woman, her relatively higher levels of estrogens mean that the woman generally will have smaller but more abundant cells. And so the aromatization is relatively modest because it is as a cell undergoes hypertrophy that its aromatization capacity starts to increase. Now, this becomes very relevant in men because in men who start to gain more weight, they generally will gain more weight through hypertrophy. And so in the man, he can start to have substantial estrogen production from his fat tissue. It's as if his larger fat cells are behaving like ovaries and aromatizing the androgens, converting them into estrogens. This is why some men, as they gain fat, may start to store fat in more prototypical female areas, including breasts. Now, this is not to say that he is able to nurse a baby. No, that is a much more complicated process. But he's storing fat in a way that looks like he's developing breasts. That's a condition called gynecomastia. So it looks like he's developing breast, and he's not developing breast tissue. He's just storing his fat in that area, making it look like he is. All right, let's go to another one that I've mentioned a couple times. This is TNF-alpha, tumor necrosis factor alpha. It is one of the most famous cytokines. You've probably heard of C-reactive protein or CRP. That's probably a little more famous, but TNF alpha is a close second, particularly in the research realm. It's not commonly measured in clinical settings, but we rely on it a lot as a signal of inflammation. TNF alpha directly causes insulin resistance. In fact, this is why in the past you've heard me talk about inflammation as a primary cause of insulin resistance. It's because things like TNF alpha can just come to a cell and cause that cell to become insulin resistant. Now, beyond the insulin resistance is just the effects of chronic inflammation, like promoting atherosclerosis and heart disease. So there are more consequences with this. Now, think for a moment. Given everything I've just described, how do you think TNF-alpha levels are affected by adipocyte hypertrophy? Does the swelling adipocyte create more TNF-alpha or less? Yes, it creates more. I'm sure that's what you were thinking, and full marks for you. So as the adipocyte swells, so too does TNF-alpha production. It goes up accordingly, promoting more insulin resistance and promoting more inflammation. Now let's get to one other one that I'll be very brief with, because I still have one more that I want to spend some time on because it's just so fascinating. It's going to blow your mind. So this next one that I'll be brief with is also a cytokine, but it's also a hormone because it flows from one cell type and impacts another through the blood. But it's also a clotting factor. And that by clotting, I mean clotting, a blood clot. And this molecule, this hormone, is called plasminogen activator inhibitor 1. Isn't that a mouthful? It's such a mouthful that we will just say PAI1. And if you want to look it up, you can just type in PAI1 and you'll get all the hits you want. So PAI1 will directly promote the formation of clots. Well, it actually prevents the breakdown of clots, because it's one thing to form a clot, but we have in place mechanisms to get rid of the clot through a normal process. Because sometimes we want a clot. Sometimes we want to stop blood from leaking out of a blood vessel if it's a bruise or a cut or whatever. But we need to be able to break those clots down. PAI1 stops the breakdown of the clot. And thus, someone with more PAI1 will have a greater tendency to form clots. And this could very much be at the heart of why people who are overweight or obese have a much higher risk of heart disease, mortality, or complications. Because if you're just forming more clots, you're going to have a much easier time developing a stroke or an infarction or heart attack. Now, I'm sure you've already come to this conclusion, but just to confirm it and put a fine point on it, the larger the fat cell gets, the more PAI1 levels go up. Okay, the last one. Some of you more astute students in the metabolic classroom have been wondering about the other fat depot that I've not mentioned yet today. We've talked about subcutaneous fat. We've talked about visceral fat. Can you remember the other one? Brown fat. So brown adipose tissue is a unique fat type. And yes, even it is involved in the endocrinology of adipose tissue, producing several hormones. I only want to mention one, and that is triiodothyronine. Now, do you hear something familiar? It is a long, multi-syllabic hormone, triiodothyronine. This is the active form of thyroid hormone, also called T3. T3 is heavily produced from brown adipose tissue, but not all the time. Now, let me just explain this in a little bit of detail. You're, of course, very familiar with the thyroid gland. Thyroid hormone is one of the most important signals in the body for setting metabolic rate and overall metabolic health. Higher thyroid hormone within reason generally is going to be a metabolically favorable scenario. Now, please, emphasis italicized, within reason. If it goes too high, it just becomes purely harmful, purely pathogenic. But on average, people who have slightly higher levels within a physiological range with T3 will be a little leaner and less more resistant to things like weight gain and diabetes and insulin resistance. Now, the thyroid gland produces a relatively modest amount of T3. It produces relatively more amounts of the inactive form called thyroxine, which is T4. And then T4 will have one of the iodine molecules stripped off of it as it moves into various tissues throughout the body. So the thyroid gland releases T4. Tissues throughout the body will pull in the T4 and release it as T3. And so the whole body is sort of helping in this process of actually creating T3. And when brown adipose tissue is turned on, like through cold therapy or through a little bit of caffeine or through exercise, when brown adipose tissue is turned on, it becomes the highest producer of T3. It begins pulling in more T4 than any tissue and releasing more T3 than any tissue. And this, of course, this is a potent activator of metabolic rates. So therefore, cold exposure is not only stimulating brown adipose tissue to burn more calories and produce heat, but it also enhances the local production of T3 or the conversion of T4 into T3, making something like cold immersion one of the most potent stimuli for increasing thyroid hormone, active thyroid hormone production. And then that T3 not only further stimulates the brown adipose tissue itself through a process that we commonly refer to as an autocrine effect. So autocrine is when a cell produces a hormone that stimulates itself. But then there is, of course, the endocrine effect, which is when the brown adipose is just releasing the thyroid hormone into general circulation. I know cold therapy is uncomfortable. Believe me, I know. As much as I've done it in the past, I still just shudder to actually get in that bath and shiver. But I try to do it. All right. That is it for the day. So we've talked about some of the sex-specific differences, mostly as a result of sex determining where we store fat, but then also the complications or the mystery of menopause when it comes to metabolism. And then we covered some of the specific effects, not only what the hormones do, but also how they are changed when fat cells get big. Leptin, adiponectin, estrogens, TNF-alpha, plasminogen activator inhibitor 1, PAI1, and T3, the active form of thyroid hormone. Thanks for tuning in. I hope that this has been a very insightful and enlightening conversation, and that you feel like you know a lot more about the endocrinology of adipose tissue. Until next time in the Metabolic Classroom, remember, more knowledge, better health.